All right, if everyone wants to take their seat, we're going to kind of go around the room, have kind of the moderators summarize a little bit, and then we have time, since it sounds like we probably could have provided more time during this session for people to ask questions, or we'll kind of use maybe the next 10 minutes or so to ask questions as we go around.
All right, so this station was talking with the student or identifying students who may not be right for EM. And so every group sort of voiced the sentiment that this is really one of the hardest things that we have to do, particularly when students are really interested and want to do EM, and we have to talk with them about the fact that we don't think that they're a viable candidate to match in emergency medicine. We talked about really trying to pin down what makes the student not right, whether it's a personality issue, the words rigidity, pensive were commonalities there, whether it's more medical knowledge issue, if there are other professionalism, red flags in the application, and then we talked about IMGs and how that conversation can be difficult. An important point was making sure you separate from not right for maybe your ED or your program versus not right for emergency medicine at all. And so what to do when you do identify these students? Practice having the conversations. They're really difficult conversations to have. The more you have somewhat, the easier it gets, but you at least get some more experience. Encouraging students to dual apply or have a parallel plan, reframing the conversation of, we want you to have a job when you graduate from med school, and I don't think emergency medicine is going to provide that for you. So what is your backup plan, or what is your parallel plan here? Begin the conversations as early as you can, and use whatever data you have, whether it's the NRMP match data, or whether it's synthesizing qualitative comments off their evals for them and just sort of giving them everything sort of listed together so they can see, and then involving your allies, if it's your program director, your chair, the deans of the medical school, so that it's not just you saying, hey, we don't think you're right for EM, or you shouldn't go into EM, but it's everybody's message that for these reasons we really think emergency medicine is not the best path forward. So,
and I'm saying, someone who's done this a couple of times now, we teach our residents to do breaking bad news. This is kind of what it is. I've had one student who never met with me again, after having that discussion. Next time I saw her was actually at SOAP because, she didn't match. And, it's heartbreaking obviously to see the students there. Her response when I said, I'm sorry this happened, she's like, well, it's not like you didn't tell me. But again, like I said, it is that breaking bad news to these, some of these students who, it's been a lifelong dream to do EM, to say, it might not be the right one for you. So go ahead.
Oh, something else I was thinking, because I really like what you said about the, I really want you to have a job. I think another good way to maybe kind of bring this up or to get insight into their views would be to say something. To say okay, sorry. So after you said that great comment about phrasing it as I want you to have a job, I thought another good thing to say to somebody might be, so tell me why you think EM's a good fit for you, and that might give you some insight into why they're so determined or passionate, or what their focus is, and you may be able to help kind of break down then why you feel that might not be true or a good fit for them, and it may just be a good way to open the conversation. Yeah.
And we talked to you in the last group just about that too, like getting them to reflect on what they enjoy about emergency medicine, and also what they think maybe their strengths are, and then trying to help them see like maybe what they enjoy the most about emergency medicine is the very smallest percentage of what we do, and really emphasizing all this other things, or really maybe what they're really great at is just a very tiny skill that we'll need in emergency medicine, but how all these other skills kind of make up a bigger skill set that they'll actually need.
All right, why don't we go ahead and move on to the low-performing student?
Cool. So we had some great discussions on the low-performing student, and actually quite a bit of overlap with, because low performers may not be right for EM. Those tend to go hand in hand. So we did talk a bit about expectation setting and things you talked about, encouraging maybe parallel pathways for the students who are on the low-performing side and probably not going to excel. But then the question is, how do you help these low-performing students, and what are some ways to do that? And so we had a number of discussions about being proactive with mid-rotation feedback. That's sort of the first time we're able to sit down with students going through the clerkship and say, here's what is going on now, and here's how you could maybe improve. The problem is, and this has been true at our institution, it sounds like at many others as well, is that you may only have one data point, only one evaluation filled out by the mid-rotation point. And so what do you, if that? And so what do you do to provide feedback at that point? And someone else pointed out that even earlier interventions would be even better, earlier than mid-rotation. Someone brought up that at their institution they have a culture of openness where if an attending or resident works with a student and they're concerned about that student, they will just notify the clerkship director right away, early on, after 1 or 2 shifts. And that's all it takes really to identify that behavior is really 1 or 2 shifts. And so really supporting a culture where it's okay to say that you're concerned about a student early on and bring that information back early so that you can intervene earlier. We talked about there's a great approach, these learning moments where, what institution are you at again? At Boston Medical Center, where they have their students fill out online 2 learning moments that they picked up from their shift, and then those are logged, and so then the clerkship director can go over with them and see, here are the things that you've learned from this rotation, and sort of like take some objective moments and use those as moments of growth or to build on, you know, sort of moving forward or in their letters. Encouraging strengths is always positive. And then we had 2 sort of interesting questions that came up, and people had different views on this. One was, is it okay, since we want to intervene early on problematic students, is it okay to sort of pre-screen them and look at what their grades were in their clerkships leading up to emergency medicine? Or is that an ethical dilemma because it introduces bias ahead of time, and then you may be sort of biased in how you view that student before they go into the clerkship? So that was one question that came up. And then the second was, what do you do about personality issues? So everybody encounters the sort of like asshole student occasionally who may not do well, but there's no sort of checkbox on the SLOE that says, you know, this guy's an asshole, so that people know that. Is it okay to be judging people's personality? Is that feedback that's okay to give? And if so, how do you give that? And that certainly can play into low-performing students, as personality issues can. But what is the appropriate way to approach that and provide that feedback? So that's just sort of a question to consider. We don't have a magical answer for that.
Yeah. Any other questions or thoughts about that?
So just one thing about the kind of pre-screening question, because this has come up at our institution quite a bit, and it is an issue because you don't want to bias your attending staff, your residents, against this one particular student. You know, as the clerkship director, the Office of Student Affairs, we meet regularly and kind of go over who the problem children are, the students with issues in either academic or professionalism. If it's really a concern, and since our rotation's in their 4th year, this is a graduation requirement, like, they may not graduate if they don't do well. What I've done is I've reached out to the site directors without giving any specific information, just be like, hey, this student is rotating with you. Please just make sure that, you know, the daily evals are getting done, and if you could just send me those, you know, before the final eval is done, I'd appreciate it. So don't try not to introduce any additional bias, but it does let them know that it's someone that we're interested in following.
We had a similar situation. We have an advancement committee, or kind of we call it the Lights Committee, but they meet every other week to go over the academic standing of certain students. And green is, you know, a student who doesn't have any issues at all. Yellow is one competency failure. Orange is the next level, then brown, then red. And students who are one competency away from failing have to rotate at the home institution. They're not allowed to go out to the satellite sites. And that for us has been a good way of keeping the students where you know they're getting good supervision, but you're also not letting the whole faculty know, hey, this person's repeating a year, or, you know, they had an LOA, or all those things. So that's the way we look at it. But I've struggled with that too. We'll often also, if a student's struggling and they have to, let's say they have to remediate 5 shifts, we'll keep them with a core group of educators. And we may not even tell them that student's repeating a shift, but, you know, they're going to go in and work with Kandawal, our residency director, and you know that he's going to be engaged with the student. He has a lot of experience in those issues. So there's no right way to do this, I don't think, but I think the way you do it's a good way.
And that's actually the way we do it. It's very similar with Nick. So we have our clinical academic review board where, yeah, if you're struggling, because there's also a basic science one, so if you struggle, you get, if you fail just like one of the sequences, it's kind of like, more or less forgiven. But if you fail 2 of them, then you add what's called academic warning for us. And as you accumulate these, you eventually get to actually going up for dismissal. So if any of our students are at academic warning, we actually require them to rotate with us at our main site also. And that way, kind of like what Will said, if the student's struggling, I tend to hear about it from, people right next to me in the office or residents that I run into. So I have a better idea of how well they're doing. So if they are truly struggling, at risk for failure, I can intervene early on versus waiting to, like you're saying, where, some of our satellite sites, I'll get 1 or 2 during the rotation, and the rest of the evaluations I'll come in afterwards. Now, we've had students who have said, yeah, but that was like early on, that was first year. And we'll look at that and say, it was only first year, and we will kind of let them rotate at other sites as long as during their core rotations they have not had any issues. But we do actually ask them they need to petition to be allowed for doing that. I still give them the warning that, yes, that's fine, but there is that chance that your evaluations are not going to come in, in a timely manner, so we may not know until later on if there's issues. So we've had 2 students last year who were really close to failing, and they were at our 2 sites, our 2 other sites, our non-U of M sites. And actually we actually did identify early on. I got an email from one of our faculty that says, hey, I normally one of those that give everybody 9s. As Will said, that's like senior resident level, but I'm really worried about this student. And it's one that we try to intervene on early and end up not. So when he did makeup shifts, kind of like what Nick said, he worked with kind of our educational faculty. And the faculty, it's not like we call these out as the faculty, like, hey, this is a student who was unengaged, because that was the main part of it. It was a student who, he saw like the first patient and then disappeared. So again, we left that alone. I told the student, you just need to do well in these. I think we did like almost a half rotation he had to make up because of how poorly he performed, and it worked out fine. But again, so we do something similar to Nick, that if they're struggling or potentially struggling, they rotate with us.
All right, so a couple things I learned from this. This is my first opportunity to participate with this Clerkship Directors Boot Camp, and I think you get partway through the session and you start kind of learning what people's experience levels are. And so I just want to, on the record, make a couple plugs. I plug Clerkship Directors in Emergency Medicine a lot. I'm a past president of that organization, and I think Luan is the president-elect when she comes back in. So, and you all have been involved for years and years and years. So you were a director, you were a program chair, or? Still are. Okay. So, so Kendra's going to oversee our track, which our track actually occurs at Cord, because that's where a lot of the educators go, but we're an academy of SAEM. Anyway, that aside, Clerkship Directors in the past has put together some good documents on recommendations for a core clerkship in emergency medicine. So if you're really getting started on the ground floor, one of the things that we didn't talk about today was even just what are the objectives for my rotation? What is the PXDX, or the required diagnoses and procedures we want students to do? All those things are in the CDEM curriculum that you can find on PubMed, or you could email one of us and we'll send it to you. I think we geared this to the level of you have kind of, this is a 101 mixed with a 102 course, but if you really need the intro to 101, we can get you that as well. So I just wanted to make sure I said that. You may have that in some of the slides.
Well, I was going to say, someone actually had brought up, like, I'm trying to find the national end of shift evaluation. Where do I find it? So yeah, at the end, like our last slide, it's got all our email addresses, so feel free to email us and we can send you that information. We did not submit a document or a handout because, again, we're all busy, and I was just glad I got the slides done. So that's something that we can easily, send off to people so they can kind of look at it. Because again, like I said, both the national end of shift evaluation card is published in WestGem, so that's available online. Like I said, the CDEM has about this material online. So both of those would be things to look for. But again, we can actually send you those citations if people would like afterwards.
Yep. So as far as the AAMC standardized video interview, the reason that I thought about that is, like, some people had not had any experience with this yet at all. So, so for those folks, just briefly what this is 2 years ago the AAMC decided to add in a standardized video interview to look at interprofessional collaborative care and professionalism. They thought that those were two competencies that residency directors didn't get a lot of information on. So as far as what residency directors get, they get a lot of information on medical knowledge, right? Because they have STEP scores and they have the EM shelf. And they get a lot of information on patient care because they have the SLOs and they have their evaluations that they can look at. But this past year was the first year students were kind of quote-unquote required to do this. It was a pilot the year before that. And so some of the themes that came out of our little small group is that a lot of people didn't have any experience with this at all. At a lot of institutions, they weren't really sure how to advise students, so it was more student-driven. We had some folks come through our group that are involved on the residency side and had mentioned that they weren't using it at all, they weren't sure what to do with the data, or they were only using the outliers, which is a lot of what we heard on the listserv. So if you scored in the single digits, that's a red flag, but anything else, who cares, kind of thing. And then there were a few folks that came by that had a prep program, and one of them was a videoed one-question video response. One was an in-person kind of mock interview with feedback. And one was a presentation on, this is what the SVI is, here's what you should do, here's what you shouldn't do. Joe and I were involved in a prep program where we had students answer questions, videotape themselves with either a laptop or a smartphone, and send us the video, and then we gave them feedback. And we're presenting that tomorrow as an innovation, so if you want to learn more, you can. Our students did pretty well. This is anecdotal. I feel like we have decent students as it is, so I think their score range was between 16 and 25, which it's out of 30. But the follow-up question a reviewer would ask me is maybe they would have scored that whether you had this or not. I mean, obviously we didn't put people into a control arm and a intervention arm because we want all of our students to do really well. So that was our experience with this. But I think the take-home points here are the more experience students get in answering difficult questions, the better they're going to do on their interviews. And if it were up to me, at least this was a mandatory mock interview that students had to do. So take-homes are, I would recommend offering some type of prep for your students. You're up.
So here we had a lot of interesting discussion about the number of EM rotations that you recommend that your students do. And I wish I would have put like 1, 2, 3, 4 and made everybody vote, because this doesn't really make any sense now that I'm looking at it. But the consensus that I took away was that everybody recommends at least one home rotation, with everybody having different requirements for potentially an elective and then a required home one. And then it kind of varied on different people recommending 1 to 2 aways. Some people thought 2 aways in addition to the home was the way to go, and then going up to potentially 3 aways if there were extenuating circumstances. Extenuating circumstances being, are there geographical places that you wanted to be? Are they a weak student? Are they couples matching? Were the main things. And then we talked a little bit about how there are some specialty EM rotations with tox or PEM or ultrasound that are not really factoring into how many EM rotations. So if I had to put a number on what everybody told me, I would say 2.5 rotations was the recommended one. But again, regrettably, I didn't have everybody vote, so my apologies.
And if I could just, I'm plugging these things, but, our specialty is one where there's these different fragmented groups, and sometimes you don't know who's doing what. But there is a CORD, EMRA, SAEM Medical Student Advising Task Force, and they meet primarily at CORD. Are any of you on that? Or okay, you can speak about it better than I can because I'm not on it, but I use their resources. And so this group came out with some resources that you can provide your students. And there's like 4 documents. One's a calendar, one's advice for the EM applicant, one's I think on away rotations. And I make sure I get those to my students. You can find those online. They recommend 1 away if you have a home institution. So I just wanted to throw that out, that there is kind of a formal guidance on this, but the things that you mentioned are kind of things that we talked about before we even met. But do you want to talk about that task force?
So it has been officially upgraded to a committee.
Oh.
Yeah, just this past year, and so still working on a new name. But yeah, it's really great because they really tried to provide evidence-based guidelines. So it's not just one person's opinion about what should be done, but really making sure they're pulling all stakeholders, students, as well as program directors and clerkship directors. And then they're really working on distributing that information, not just to clerkship directors, but also to medical school deans, because sometimes you may give advice and your program director, you guys are all on the same page, but then they go to the dean's office and the dean's like, apply to 70 programs. And you're like, no, but that's hard for the student to sort of let go out of their mind. And so, yeah, so it's a great task force if anyone wants to be involved. It's a great opportunity to meet other people. It's off the. You can get to it. CDEM has links to it. Yeah.
So it's out of, was it Cord EM?
It's a joint task force through Cord, SAM, and CDEM.
Yeah.
But if you Google CDEMcurriculum.com has a lot of these resources. That's a good place to start. So it's funny because I just put together a student advising WordPress site, because there's so many different. EMRA has resources, SAM has resources, CDEM has resources, so does Cord, and so and so does AAMC when it comes to the SVI. So if you're really getting in the weeds with advising students, finding these resources is absolutely the place to start. But the other pearl that I would say, and I always tell students this, is we're going to have a meeting with all of you on advising, but all of you are going to have a separate meeting with me, because until you know what their Step 1 score is, their grades on their Med 3 clerkships are, their Step 2 score is, what their slows look like, you can't really accurately advise a student. And if they're getting advice from like student forums online or from other students, that's usually not good advice, because those other students don't know that this person took an LOA and they had 2 cracks at Step 1. That's information that you need to advise. So use those documents, but also make sure you're meeting with your students.